नमस्कार दोस्तों, my name is Kamal Yadav. You are watching Kamal Yadav Mahal Learning Coding with Kamal. So let's today discuss that top 15 E&M questions. So out of 15, we decided top 10 E&M questions for interview. What does modifier 78 indicates? Modifier 24 versus modifier 25. Modifier for the secondary surgery in global period. Office visit E&M code elements. Established versus new patient. LCD and how is it used? A screening colonoscopy example. Knee arthroscopy guidelines and compartment. Closure repairs for lesion excision. ICD for HIV positive versus AIDS. So please watch my video till the end and subscribe my channel. You are learning coding with a Kamal Yadav. Disclaimer: this video is created solely for the educational purpose and provided general information related to medical codings and billings. The content based on the professional experience, publicly available information and commonly accepted doing the coding practices. Every effort has been made to the ensure accuracy. However, this material should not be considered official codings, billings or legal advice. All credit for the original concept, images and references materials belong to their respective creators and sources. No copyrights and fragmenting intended. Let's discuss the 15 questions. Out of 10 we'll discuss separately in this video. What is the difference between modifier 24 and 25? What does modifier 78 indicates? If patient in a global period on of the surgery within a global period another surgery has been taken, then which modifier you will use for secondary surgery? What are the basic elements of office visit evaluation and management? What is the difference between established and new patient in a E&Ms? Please explain. What do you mean by LCD and how it can be used in coding? Please explain. Can you please a screening colonoscopic guideline with appropriate example from Medicare perspective? Knee arthroscopy and how many compartments? Please name them. For the excision of lesion, how many types of closures or repairs are given in CPT book integumentary section? Please name. What is complex repair? What is difference between segmental and non-segmental spinal instrumentation? What are the two component of radiology code? As per ICD conventions, how you will give the difference between HIV positive and HIV positive and AIDS? What is difference between outpatient consultation and inpatient consultation? If any physician or same specialty group physician is doing consultation more than once in a hospital stay for the patient, then how you will code first services and subsequent services perform on the next day? How you will be code critical care services for less than 30 minutes? Name the few services which are included in critical care management. Let's discuss in the next slide. First question was coming out of 15, that is what is difference between 24 and 25 modifier? 24 modifier, 24 modifier unrelated E&M service, 25 modifier same day modifier, 25 extra E&M service. Difference between 24 versus 25 modifiers: 24 modifier unrelated E&M service used for unrelated evaluation management service by the same physician during the post-operative period. What is the star mark here? Unrelated condition during post-operative period. Bonus of what is there? 24 unrelated E&M service during post-operative. So these points should be remember. 25 modifiers significant E&M service used for significant separately identifiable evaluation and management services on the same day as a procedure. Same day visit, separate E&M with procedure. What is remember things we can remember? Modified 25 significant service same day as procedure. Let's discuss in the detail. Modifier 25 significant separately identifiable services on the same day. Definition: Modifier 25 is used when the significant and separately identifiable ENM service is performed on the same day as a procedure. Key points: use only with the ENM codes. ENM services and procedure occur on the same day. ENM service goes beyond the usual pre-procedural work. Append to ENM codes. Example of 25 modifier: a patient visit for knee pain. The physician performs full evaluation and then gives a knee joint injection. Coding: ENM codes, for example 99213 with 25 modifier, joint injection code 20610. Note: because the evaluation was separate and significant, not just the injection decision. Hope this point is clear for you. What is difference between 24 and 25 modifier? Here the complete answer with a clear example preferred for interview notes. 24 modifier unrelated ENM service during the postoperative period. Definition: 24 modifier is used when evaluation and management services is performed during the global post-operative period for surgery, but the visit is completely unrelated to original surgery. Key point: use only with ENM codes. Service occur within a global period. The condition treated is unrelated to surgery. Append to the ENM code. Example of 24 modifier: a patient had a hernia repair, 90 days of global period. 2 weeks later, the patient visit the same surgeon for uncontrolled hypertension. Coding: ENM codes. Example 99213 with 24 modifier. Note: because hypertension is not related to hernia surgery. Modifier 24 versus 25. Quick comparison. Features: modifier 25, modifier 24. Yes, 24 is we can use. 25 modifier, no. Same day surgery as a procedure, 24 modifier, no. 25 modifier, yes. Related to surgery, like here, unrelated. 25 may be related. Used with ENM codes, yes. 24, yes. 25, yes. Easy memory tricks: 24 post-op plus unrelated problem. 25 same day plus extra evaluation. So this is the key points we can say. Let's discuss the inner one line interview answer. What is difference between 24 and 25? One line module answers is there. Modifier 25 4 is used for unrelated ENM service during the postoperative period, while 25 modifier is used for significant separately identifiable ENM services performed on the same day as a procedure. Let's discuss the second question which are commonly asked, that what does modifier 78? Medical coding 78 modifies unexpected return to OR operation room, unplanned procedure during post-operative period due to complication. What does modifier 78 indicates? Modifier 78 indicates an usual return to the operating room OR by same physician during the post-operative global periods for the related to procedure due to a complications from the original surgery. 78 modifier indicates an unplanned return of the operating room by the same physician during the post-operative period for the related procedure due to complication from the original surgery. Simple definition, one line answer for the interview. Modifier 78 is used when a patient is taken back to the operating room unexpectedly during the global period for the related procedure due to complication. So you can told that 75 78 modifier used when the patient is taken back to the operating room unexpectedly during the global period and that related to procedure due to complications. Key points to the remembers interview tips we can remember. This is an unplanned return during global period. Same physician, related procedure must be operating room. Payment is reduced intra-operative period only. When to use 78 modifier? 78 modifier use patient develops a post-op complication. That time we can use. Physician must have performed another surgical procedure. Procedure is related to original surgery. Patient return to the OR operating room. So that time we are using 78 modifier. When not to use 78 modifier? Planned surgery, planned procedure use modifier 58 rather than 78. Unrelated condition use modifier 79 rather than 78. Office visit modifier 78 not applicable. Different physician 78 modifier not applicable. Please remember these things. Coding scenario example very important. Let's discuss that. Example post op bleeding. Scenario is here. A patient undergoes hernia repair. 2 days later, during the global period, the patient developed the bleeding and is taken back to the operating room for the controlling hemorrhage. Okay, coding tips. Control of bleeding code modifier 78. We will use this because it is unplanned, related and done in the OR room. So this is related to original surgery and this procedure control, bleeding control is done into the operative room. So we are using 78 modifier with the bleeding control CPT. Example 2, wound dehiscence. Scenario, a patient has abdominal surgery during the post-operative period. The surgical wounds open and the surgeon takes the patient back to the operative room to close the wound. Coding tips. Wound closure procedure 878 modifier. Example third is given infection and drainage. Scenario, after knee surgery, patient develops an infection at the surgical site. The surgeon performed the incision and drainage in the OR during the global period. Coding tips, what will do? CPT incision and drainage with 78 modifier. Interview comparison line bonus answer, what we can told that modifier 70 is a different from 58 because 78 is a unplanned while 58 is a planned or stage related modifier. One line memory tricks. 78 modifier unexpected return to the war room due to complication. Easy examples, interview friendly, we are giving example. Modifier 78 unplanned return to the OR. Scenario, patient had gallbladder surgery during the postoperative period. Patient develops bleeding and taken back to the OR. Control bleeding CPT 78. Complication plus return to OR. This is the problems why patient came. Modifier 58 planned stage procedure. Scenario is given here. Patient undergoes biopsy. Pathology confirmed the cancer. A more extensive surgery is performed during the global period. Coding team definitive CPT code CPT 58. Planned and more extensive. So we are using 58 modifier in this scenario and above scenario we are using 78. 79 modifier unrelated procedure. Scenario, patient has a knee surgery during the global period. Patient has unrelated skin lesion ex excision. Coding skin lesion CPT 79 unrelated to the original surgery. Original surgery had happened on knee. Now skin lesion is excised. That's why we are using skin excision CPT with 79 modified. I hope you are understood 78 modifier, 58 modifier, or 79 modifiers. These comparisons are asking by the interviewer in every interview. So be ready and remember these all examples for better your understanding. Medical coding modifiers comparison, already we discussed that. 78 unplanned or returns, unplanned return, you can check this. So this 78 is a reduced payment, 58 is a full payment. In this scenario we are getting a full payment, 79 is like a full payment, so you can get this. 78 versus 59, 79 we already discussed this all things, so you can take the fee reduction. 78 50%, 58 none, or 79 none. Global period restarted in a 78 no, 58 yes, 79 no. Okay, super easy memory trick. We are saying that 58 planned and stays, 50 and 79 returned to OR due to complications, 79 totally unrelated. One bonus tips, one line answer for these questions. Modifier 59 is a planned or stage procedure. 78 is the unplanned return to the operating room due to complication, and 79 is the unrelated procedure during the global period. So you can tell in a one line sentences. Let's move to the third question. If a patient, you will see here, if a patient is a in the global period, one surgery or another surgery is performed within the global period, which modifier is used for the second surgery, right? One surgery is performed within a global period and second surgery also performed, so which modifier will be appropriate to report with the second surgery? Answer with a clear example exactly how interviewers expect it. Correct answer, key concept. Let's see. The modifier used for second surgery depends on the relationship between the two surgery. Modifier 58, 78 or 79 may be used, not a single fixed modifier. How to decide the correct modifier? Golden rule. Ask three simple questions. First question, is the second surgery planned or staged? Second question is it related or unrelated to the first surgery? Was three was there an unrelated return to the operating room due to complication? So before we are coding second surgery, we need to ask three questions. Modifier selection with example. Modifier 58 planned staged more extensive surgery. When used, second surgery is a planned, anticipated, or more extensive, related to the first surgery performed during the global period. Example, patient undergoes biopsy of the breast mass and pathology confirm malignancy during the global period. Lupectomy is performed. See coding, what will code? Lupectomy code with a 58 modifier, planned and more extensive. So we can use 58 modifier. Modifier 78 unplanned return to the OR complication. When to use? Second surgery is unplanned return to the first surgery performed in the operating room due to postoperative complications. Example, patient has a hernia repair during the global period. Patient developed the postoperative bleeding and taken back to the OR. Coding, control of the bleeding CPT code with the 78 modifier, complication return to the or modifier represents 78. 79 unrelated to surgery, when to use? Second surgery is unrelated, new condition during global period, same day, same physician, sorry. Example, patient has a knee surgery during the global period. Patient undergoes the skin lesion, already discussed skin lesion with a 79 unrelated condition due to we are using 79 modifier. Quick comparison for the table. For the interview purpose, situation, planned, stage, or more extensive using 58, unrelated return to or complication using 78, unrelated procedure using 79. Perfect one line interview answer. If another physician is performed during the global period, modifier 50 is used for planned stage related procedure. Modifier 78 for the unplanned return to the operating room due to complication, and 79 modifier is used for the unrelated surgery. So you can remember online questions. Easy trick: 58 planned, 78 return to or 79 is unrelated. What are the basic element of ENM visit CPT codes as per new update? One line answer, what we can say, told that interview online answer perfectly we can say that as per current CPT update, office visit codes are select based on either MDM decision making or total time spent on the date of encounter. History and physical exam are no longer key components for the code selection. So you can explain these question like answers. If someone asks what are the basic elements of office visit ENM codes, so you can tell that update soul office visit ENM codes 992022 to 99215. Elements of the code selection is a medical decision making, MDM, total time spent. That's two key components. Great question. A very important after 2021 to 2025's ENM updates. So let's discuss this question in a detail. Here the correct updated answer with a clear example exactly how interviewers expected it as per current CPT guideline. Correct updated answer 9 and 2022 2021 to 2025 CPT rules. We can take the references. Office visit code 99202 to 99215 are now selected based on the medical decision making, MDM. Second is a total time spent on the date of encounter. History and physical exam no longer key component for the code selection. They are requiring as a medical appropriately. Element 1, medical decision making, MDM. MDM is based on the three sub elements. First is a number of complexity of problem address. Examples are there: self limited or minor, stable chronic illness, acute complicated illness, chronic illness with exacerbation. B is a amount and complexity of data reviewed, include lab test, imaging, medical records, independent historian, discussion with another provider. Risk of complication and morbidity, mortality based on prescription of drug, surgical decision, hospitalization risk. Two out of these three elements must meet or exceed to label or to select the MDM label. MDM label office visit. MDM labels or description straightforward, low, moderate, high, minimum, limited or moderate, high. So when we can explain in detail this answer. Example based on the MDM coding. Example: establish patient 99213 scenario. Patient with a stable hypertension seen for routine follow-up. Physician review the labs and continue medication. MDM problems: stable chronic illness. So we are selecting from the table low. Data lab reviewed low. Prescriptions management risk within under risk. What is this? Prescription management is a moderate. 2 out of 3 moderate. Code is 99213. So nowadays it's considered as a moderate to low. Example 2, new patient 99204 scenario: new patient uncontrolled diabetes, medication adjustment, lab ordered. MDM, let's say problem data table A, chronic illness with exacerbations, moderate. Data multiple labs order and review, moderate. Risk prescription of drug, moderate. So MDM decision moderate. Code is 99204. Elements 2, total time on date of encounters include the physician or QHP time spent on reviewing the records, patient evaluation, counseling and educations, ordering tests, documentations, care of coordination. Exclude is there staff time and time on the separate procedure. Right? Time range office visit. New codes 99202 15 to 29 minutes, 99203 30 to 44 minutes, 99204 45 to 59 minutes, 99205 60 to 74 minutes. If these times are increased, then we are coding prolonged service code 99217. For Medicare we have a different code. For the commercial we are using this CPT code. Established patient 99212 10 to 19 minutes, 99213 20 to 29 minutes, 99214 30 to 39 minutes, 99215 40 to 54 minutes. Example time based coding. Example established patient code is used 99214. Scenario physician spent 35 minutes total time reviewing record, evaluating the patient, adjusting the time, treatment and documenting. 35 minutes fall under 30 to 39 minutes. So code is 99214 time based on time. Interview one line answer. How we can explain that? As per current CPT, office visit ENM codes are select based on either MDM medical decision making or total time spent on the date of encounter. History and physicals exam are no longer key component for the code selection. Easy to memory, new ENM, MDM or time, no HPI, no history and physical exam counting. So we can remember this. Let's discuss another question. What is difference between a new patient and established patient? You will see here question. One line answer we can told that a new patient is one who has not received professional services from the same physician or same specialty within the same group practice in the last 3 years, whereas an established patient has received the services within that period. What is the differences between new patient, established patient? We have discussed in detail. New or established. See here. New is the first time met. Established is already taking services. Great question. This is asking in an interview. This classic ENM interview topics here clear, updated and exam ready explanation with examples. Official CPT definition. New patient. A new patient is one who has not received any professional services from the same physician or another physician of the same specialty and same group practice within the past 3 years. Established patient. Who An established patient is one who has received professional services from the same physician or same specialty within the same group practice within the past 3 years. Key role. The 3 years rules is a deciding factors. If any patient who has a gap between 3 years first visit to second last visit, then we can code new. If within a 3 years patient is coming, so we are considering as a established patient. Key differences at a glance we can check. Factors: new patient, established patient. Prior visit in a last 3 years, new patient no, established patient is a yes. Same specialty, same group, not seen, seen. Established patient is a seen. CPT code range is a 99202 to 99205. Here established patient CPT code is a 99212 to 99215. Typically higher complexity, yes. New patient having yes, or established patient having a usually lower. Important point for the interviewers, what they like: same group, same specialty, consider same physician. Different specialty in a same group can be new patient. Different specialty in a same group is can consider new patient. Different group practice, new patient. Place of service does not matter. Example, very important. Example 1, new patient scenario. A patient visit Dr. A, cardiologist, for the first time. The patient has never seen any cardiologist in that group in last 3 years. Status: new patient. Code range we can take from 99202 to 99205. Example number second, established patient. A patient saw Dr. B, internal medicine, in the same clinic 1 year ago and returned for the follow up. Status is established patient. Code range started from 9921322 to 99215. Example 3, same group, different specialty. Scenario 1, a patient saw Dr. X orthopedic last year. Now visit Dr. Y neurologist in the same group. Pas- Patient status is a new different specialty due to different specialty. Example 4, same specialty, same group. Scenario is here, patient saw Dr. M, dermatologist 2 years ago, now seen another dermatologist in the same group. Patient status is established patient, same group, same specialty plus same group. In medical coding interview, second, third, like next question is here. In a medical coding interviews, LCD is a very important concept. Below the clear and interview related explanation with a simple language explains and exactly way to the interviewer expected. One line interview question, someone asks what is the LCD and how it is used. So we can tell that LCD is a regional Medicare policy issued by the MAC that defines the coverage, diagnosis requirement and medical necessity for the specific services. Coder used for LCD to ensure the correct ICD-10 code selection and avoid the claim denials. LCD is a local coverage determination. What is an LCD in a medical coding? Local coverage determination. Medical necessity, coverage indications, documentation requirement. So three key components we can say that. Let's just discuss in the details. What is a LCD? LCD stands for the local coverage determination, and LCD is a policy issued by the Medicare administration's contractor, that is called MACs, that explain the which service are covered, when they are medical necessity, for which diagnosis ICD codes, under what condition payment will be made. LCD apply only a specific region of MAC, as we had discussed the medical administration contractor, unlikely NCD which apply the nationwide. LCD, why LCD is important in a medical coding? LCD help to the coder select the correct ICD code, support medical necessity, avoid a claim denials, ensure a Medicare compliances. If diagnosis code does not match the LCD, the claim may be denied even the CPT code is correct. How LCD used in the Medicare coding, step by step we'll try to understand. Step 1, identify the CPT HEFIX code. Example is given 83036 hemoglobin A1C. Step 2, check the LCD for the services, LCD list, covered ICD list, frequency limit, documentation requirement. Third step, match the ICD code from the LCD list. Only ICD codes listed LCD considered as a medical necessity. Interview example is a very important. Let's discuss scenario. A provider order hemoglobin A1C. Code is 83036 for the patient. Diagnosis is E11.9 type 2 diabetic mellitus without complication. LCD review. LCD state that 83036 covered the diabetes related ICD code including E11.9. Claim will be paid easily. Wrong example, if the diagnosis is Z000, general adult examination, claim denied. Reason, diagnosis is not covered in the LCD. Question is here, how will check the LCD in a portal, in a CMS portal? I will explain that. If you are using like a encoder or codify, there is also list available, so we can check from there. I will discuss into the separate like video. Another common examples, imagine CPT code 76700 complete abdominal ultrasound, covered ICD as per LCD R10.9 abdominal pain, K76.0 fatty liver, case 94.5 abnormal liver function test. If documentation support one of these payable, if diagnosis is like unrelated or vague, then denied. It means that if that is not supportive, so it will be denied. Difference between the LCD and NCD, interviewer asks these questions. Full form: local coverage determination, national coverage determination, issued by the MAC. Already I defined that. NCD, like CMS, Medicare, like CMS is allowed, and they are issued coverage area region wise. This NCD is a national wise. Priority lower than NCD, highest here. So you can explain in this way: if NCD exists, it's override the LCD. Key interview points to remember: LCD support medical necessity, diagnosis must LCD approved ICD-10 codes, used mainly for the Medicare claims, helps to prevent the denials and audits. One line interview questions is a very useful. LCD is a general reason Medicare policy issued by the MSC that's define the coverage, diagnosis, requirements and medical necessity for the specific services. Coders use LCD to ensure the correct ICD-10 selection and avoid the denials. LCD versus MU versus NCCI comparison. Let's see. Here the clear interview ready for the comparisons table: LCD versus MU versus NCCI, exactly how it is expected in the medical coding interviews. You can revise and before the interview. LCD versus MU versus NCCI, what is differences? LCD is a local coverage determination, Medicare coverage rules. MU is a medical unlikely edits, claim units limit. NCCI edit is a National Correct Coding Initiatives edits for the correct CPT, HCPCS, CPT, HIPIX coding. One line answer is here. One line interview questions we can tell: LCD validate the medical necessity, MU limits of the number of unit billed, and NCCT prevent the incorrect CPT code combination to ensure the accurate medical billing. So you can define in one line. Simple interview questions understandings. Let's see. LCD is, what is the LCD? Is a service medical necessity for the diagnosis. MU are too many units being built. Can these two CPT codes can be built together? So this question should become when we are asking what is the LCD MU. Real world example for the favorites, we can give the examples. LCD example here: CPT code 83036 HbA1c, ICD code Z00 point, routine exams, denied, diagnosis is not covered as per LCD list. MU: CPT 20610 joint injection, MU limit is 1 unit per day, billed with 3 units, denied, unit exceed due to MU. NCCI edit here: CPT code 36415 venipunctures, CPT 80053 is a CMP panel, denied, venipuncture is a bundled, allowed only if distinct service with the 59 modifier. So we are using 59 modifier, that time it will be allowed, otherwise it's showing the bundled. Common interview questions: what is the edits has a highest priority? NCCI, then MU, then LCD for the claim processing logic. Let's move to the next question, that is a part: what is the screening of colonoscopy Medicare? One line interview questions. Medicare covers the screenings colonoscopy based on the patient risk category. G0121 is used for the average risk every 10 years, and G0105 high risk every 2 years. If a screening colonoscopy become diagnostic due to polyps removals, modifier PT is append to maintain the screening benefits. So you can see here below is a clear Medicare focused explanations of the screening colonoscopy guidelines, which rules plus real interview style examples. This is written exactly the way interviewers expected the answer from the medical coders. A screening colonoscopy is performed on the asymptomatic patient to detect the colorectal cancer or polyps before symptoms appear. From Medicare's perspective, screening colonoscopy coverage depends upon the risk category, average versus high, frequency, correct CPT plus ICD selections, findings during the procedure. Moderate risk category, average risk patient without a personal history of the CRC or polyps, family history of the CRC, IBD, Crohn's or ulcerative colitis, genetic syndrome FAP or Lynch. Coverage once every 10 years, no minimal age changed by Medicare. It is like conditions. High risk patient. When we consider high risk, the patient with a personal history of colon polyps or CRC, right? Family history of CRC, IBD or genetic risk. Coverage once every 2 years within a 24-month. Medicare CPT codes screening. What there is two codes G0121 screening colonoscopic average risk 10 G0105 screening colonoscopy high risk. Diagnostic codes ICD like average risk Z12.11 encounter for a screening for malignant neoplasma like clone high risk example Z86.0110 personal history of clone polyps Z0 80.0 is a family history of the GI malignancy, K50.90, K51.90 Crohn's or ulcerative colitis. Key medical rules very important for the interview. As screening colonoscopy can return into the diagnostic colonoscopy if the polyps or lesions is found and removed, but Medicare still consider it as a screening benefits if done for the screening intent. Modifier used by the Medicare modifier PT used when the screening colonoscopy becomes the diagnostic or therapeutic. Prevent the patient cost sharings or deductible waves. Examples for the like there one average risk of screening that is normal scenario patient asymptomatic no family personal history of colonoscopy performed no findings. CPT code is used G0121 ICD code is a Z12.11. Paid as a screening, no deductible or co-insurance. Example, high risk screening scenario patient has a history of colon polyps. Screening colonoscopy done, no current symptoms. CPT code G0105 and ICD code Z86.0110 coverage once every 2 years. Example third is given. A screening turns diagnostic curve. Very common interview questions is this scenario patient scheduled for the screening during the procedure polyps found and removed. CPT code here 45385 PT colonoscopy with a polypectomy. ICD Z12.11 primary, K 63.5 polyps as a secondary, still treated as a screening. Modifier PT is required, deductible waived. Example diagnostic colonoscopy not a screening like diagnostic colonoscopy is performed that is not a screening scenario patient present with a rectal bleeding colonoscopy order and evaluated CPT 45378 ICD Case 62.5 hemorrhage of the anus and rectum not screening subject to deductibles and coinsurance. This will not applicable, right? You can see the tables screening versus diagnostic in a quick interview tables. You can see symptoms screening no diagnostic yes intent in a screening preventive in a diagnostic problem focused ICD you can use Z at 12.11 in a screening symptom based ICD CPT code G0121 or G0105 in a screening in a like a diagnostic 453782 to 45385 modifier PT we are using in a screening used if the converted in a diagnostic not applicable. Next question, least common interview questions is does removal of polyps change screening to the diagnostic? Procedure become diagnostic, but Medicare still process it as a screening if PT is used. One line interview questions are like that. Medicare cover screening colonoscopy based on the patient risk category G0121 is used for average risk every 10 years and G0105 for the high risk every 2 years. If a screening colonoscopy become diagnosed due to polyps removal, then modifier PT is append to maintain the screening benefit. So we can use this way. Commercial payer versus Medicare. Key differences in a medical coding. High levels of the comparison tables feature go, like given there, government given by the CMS or private insurance. We can take that government and CMS and privates. We have rules. Preventive coverage basis CMS rules, NCD or LCD. USPTS TF plan policy, like that is a pair related. So a screening colonoscopy code G0121 or here G015 here, like a preventive intent 45378 diagnostic modifier for the screening diagnostic PT 33 most of plan we are using in a commercial. Frequency rules fixed 10 years, average 2 years higher, like this. Here varies by the plan, so different depends upon the pair plan. Age criteria, no minimum age is for the screening, usually started from 45 years in a commercial. Cost sharing often waived in a, like a Medicare. Here depends upon the plan. Policy variations, less variation, here high variation. So it depends. LCD NCD used mandatory in a Medicare, usually not applicable. Appeal CMS process or pair significant. A screening colonoscopy coding difference must ask it. They are asking a screening colonoscopy difference between like that. Medicare used HIPIX G codes, screening intent drives the coverage, modifier PT maintained to the preventive benefits if the polyps removed, commercial use CPT of the colonoscopy codes, screening identified by the diagnostic or more plus modifier 33 indicate the preventive services. Examples of the average risk screening normal study, Medicare CPT code is a G0121, like ICD code G12.11, PEDS as a preventive service, no deductible. This way, commercial. If in this scenario 45378 with a 33 modifier, Z12.11 paid as a preventive. Cost sharing waived most of plan. Example second is here given a screening colonoscopy with a polyps. Very important interview scenario is it is Medicare, like 45385 with a PT. Modifier the diagnosis is use Z 12.11 primaries, K 63.5 secondary. Still processing as a screening. Deductibles waived due to the PT modifier. Commercial pair CPT code 45385 with a 33 ICD J 12.11 or K 63.5. Covers depends upon the plan. Some plans apply coinsurance after the polyps removal. Example third, diagnostic colonoscopy, symptoms present, Medicare and commercial, same logic, CPT 45378, ICD K 62.5, rectal bleeding, not preventive, not like deductibles or coinsurance applicable. Frequency differences, quick tables we can check. Risk types, average, high or age. Every in a Medicare every 10 years, every 2 years, no minimum. Age is like no minimum. Commercial usually every 10 years, varies 2 to 5 years, usually more than 45. So thank you for asking, thank you for watching this video, and we'll discuss about the LCD NCD impact in a different, so we in a next video. So I believe that you will get this point. So before closing this video, I'll discuss this related to colonoscopy, orthoscopy we will discuss in the another video. Here LCD NCD impact big differences. Medicare claim must be follow the LCD or NCD diagnosis must be support medical necessity. LCD denials cannot be fixed with a modifier. Commercial, no LCD, no NCD, follow the payer policy, benefits prior the authorization often required. Common interview questions, which modifier is used for Medicare screening colonoscopy turn into diagnostic? So you can tell that modifier PT. Which modifier is used for commercial pair? That is a 33 modifier. Do commercial pair always waive the deductible for the polyps removal? Answer is no, depends upon the plan policy. One line answer we can tell that Medicare use G codes and modifier PT for the screening colonoscopy, while the commercial payers use CPT code with a 33. Medicare follow the strict CMS rule with a fixed frequency. and LCD NCD guidance, and whereas commercial peers covers varies by the difference plan. Memory tricks, interview hacks, Medicare G codes plus PT, commercial CPT code plus 33 symptoms diagnostic, or both. How many compartment are there in a knee or knee related questions we'll discuss into the another video. Thank you for watching this video.